Good morning, good afternoon, everyone. Welcome to the PHC webinar series organized by International Institute for Primary Healthcare in Ethiopia. The International Institute for Primary Healthcare in Ethiopia is established by the Federal Ministry of Health, and it is engaged in capacity building and in South-South knowledge exchange. As part of building capacities and the learning exchange, this webinar series is planned. So welcome. It's going to be focusing on community-based health insurance, the lessons from Ethiopia and Rwanda. Unfortunately, our speaker from Rwanda was not able to present and speak today, but we are trying to make arrangement to have a follow-up webinar that would be sharing the experience of Rwanda and their lessons learned on implementing CBHI. With that, let me introduce our moderator, Dr. Matiko Riro. Dr. Matiko Riro is a medical doctor and a health economist, working with Clinton Health Access Initiative as Associate Director, Health Financing. Based in Nairobi, Kenya, Dr. Matiko Riro is leading CHI's technical support to government in Sub-Saharan Africa in health financing reforms, as well as strategic partnership with regional institutions to enhance knowledge exchange across the continent. Welcome, Dr. Matiko Riro. Over to you.
Good. Thanks a lot, Dr. Ntene, and welcome everyone to this webinar. I know it's one of a conversation that we'll wish to have more around how can we share what's happening across the continent. And one of the things that comes out quite clearly is as we strengthen health systems, of how can we use certain platforms to share knowledge in terms of what is working in other areas of the continent. And especially, we know what has come to be popularly known as the South-to-South knowledge exchange, that we know what is happening in Rwanda, how can that influence what's happening in Ethiopia. And I think one of the things that Antene mentioned earlier, it should have been our greatest wish to have the Rwanda team, but they were not able to make it. The interesting thing about the two is that they run one of the most successful programs, especially when it comes to community-based health insurance. So trying to think about how the two are making it happen, and even looking over and beyond, thinking about how they've managed to raise resources, but more so around what some of the decisions they have made in terms of managing to expand coverage, and also going to how the decisions they're making around the benefit package, that's the services they're going to provide. And some of them actually going ahead to institutionalize some of these processes in terms of just getting them to places in which they can ensure that there's efficiency in utilization of resources. And even how they're making decisions around paying providers, so provider payment mechanisms, and how, Ethiopia, for this conversation, they're making progress in terms of digitizing the process at the same time. So to kick us off, going to have, Dr. Muluken. Some of you probably know Dr. Muluken. So he's a medical doctor with a master's in global health, special focus on health economics. And currently is the Deputy Director General for the Ethiopian Health Insurance Services, where he's been for the last 2 years. He has also been previously served as the Regional Health Bureau Head at Dire Dawa, one of the 2 city administrations in Ethiopia, for the last 4 years. Previously worked as a lecturer at Dire Dawa University as a lecturer teaching basic sciences for medical students, and also served as a dean of the medical school. So with those few sort of introductory remarks, I wish to welcome Dr. Muluken. Over to you. Hello, Dr. Muluken.
Yes, Dr. Matiko, yeah. Can you hear me?
Over to you. Yeah, I can hear you well. Over to you.
Yeah, good afternoon, everyone. This is Muluken speaking. I will be presenting my slides. Let me share it. Can you see them?
Okay, yeah, now we can see your slides.
Good. Thank you, everyone. This will be the outline of my presentation. I will try to present the health financing context of Ethiopia. I will explain the rationales of implementing health insurance in Ethiopia, the design features of the two suggested or the two health insurance systems that are decided to be implemented in Ethiopia, and then I will update you the current implementation status. Finally, I will finish off by listing some lessons from the implementation of health insurance. So Ethiopia is a country located in East Africa with a population of close to 150 million as per the World Bank's report. And the life expectancy at birth right now is 66.5 years. And this is a little bit higher for women. And the GDP per capita, as per the World Bank 2015 report, is 936 USD. But some unofficial reports say that now it has crossed the 1K line. And the people under, or the population under the poverty head count are said to be 23%. The Ministry of Health had recently conducted a national health account. This is a study whereby the total health expenditure and some other related informations are going to be assessed through the country. It's usually conducted, as you see from the graph, every 3-4 years. So as per the latest information, or the last report, which was out very recently, so it studied the 2019-20 expenditure. The total healthcare spending in billions in dollars was $3.63 billion, when it includes the cost that was spent on COVID-19, and it will be $3.44 billion when we exclude the COVID. And this shows that there is increment in the healthcare expenditure compared to the study which was done like 3 years ago. When we see the three major sources of health financing, still the major share goes to the donor portion, or the donor part, though it is decreasing. As you see here, the red one shows the donors' share, and the green one shows the government's share. So the donors' share is decreasing from time to time. So as per the NHA 8, 34% of that spent money was, was collected or did came from the donor side. I did it red, or I colored it red, because as you know from health financing, it is not a recommended source of financing. And that, as you see, is decreasing, and it's not something, or it's not a finance source that a country should rely on. And definitely, as the country's income grows, the donor side will definitely drop more than this. The government, which I colored green purposely, should be something which goes higher and higher. As you see, there is a very small growth that you can see from the graph, but this should be much more higher than this. The yellow one that you see is out-of-pocket expenditure. This is a direct expenditure at the point of service. This should be redirected as a prepayment. And again, this is not something to rely on. And we need to be cautious on this one too. So a significant portion of the money, as you see, comes from a source which the system, the health financing, the health system shouldn't rely on. There are small share which come from private and CBHI coverage. So as you see, the CBHI share is very small, because this is total health expenditure, and it includes the running costs, the preventive activity costs, and the like. But this is the CBHI covers only a very small portion of it, and then I will explain what it is later on. So the rationale of implementing health insurance in Ethiopia, the first one is improving health service utilization. The Ethiopian government has had a health sector development plan, which was implemented before the health sector transformation plan that we are implementing right now. And during that health sector development plan, we have expanded a lot of health facilities. and specifically primary healthcare facilities were built throughout the country, but the utilization hasn't increased. And one of the primary reasons that was, or the primary factors that made people not to come to facility was fear of expenditure and fear of cost. So to address that part, the government wanted to introduce a mechanism or an insurance mechanism or a financing modality. So the first reason, or the main reason why CBHI was started, or health insurance was started in Ethiopia, is improving health service. But while utilizing the service, there shouldn't be unexpected OOP, and the government wanted to avoid that one too. That is the other reason. As you know, OOP will lead to catastrophe, and then might lead also to impoverishment. And also the one rationale of implementing health insurance is to ensure equitable healthcare delivery throughout the country and throughout the population income quintiles, and also improving health service quality through community ownership, because in the community-based health insurance, majorly the community will get involved. And once they prepay, they will be very demanding, and that will somehow help also in improving the health service quality. As well, there will be a predictable money that will be that on which the facilities could plan on. The other plan was also to improve the per capita health expenditure. As per the NHA 8, or the last report I was mentioning earlier, the per capita health expenditure is 36 USD, which is very low compared to the sub-Saharan African countries, which is around 40. And as well, the WHO recommended $86 money, which is needed if a country has to fulfill essential health service package for its population. So it is below both the WHO's recommendation of fulfilling, the money needed to fulfill essential health care, and as well the sub-Saharan average. So the government wanted to increase that per capita health expenditure too. So one rationale of implementing health insurance was this. So there were two health insurance systems that were designed. The first one is social health insurance, and the other is community-based health insurance. So the difference between the two is based on target population. The social health insurance targets formal sector, while the community-based health insurance, which we call CBHI in abbreviation, covers the informal sector. The informal sector is estimated to be around 81% of the population. Enrollment-wise, the SHI is primarily designed as a mandatory scheme, but the CBHI had been voluntary for the last 10 years, but now has, with a recent proclamation, which was enacted last August, so it has become now mandatory. But how it's going to be implemented is something that we are working on. Both insurance mechanisms will take the individuals as a member. Like, for example, in social health insurance, it is for the formal sector, those employed in the formal sector. So the employee will be a member, but the family or the dependents of that employee will be beneficiary. In the CBHI, the head of the household will be a member, but all the dependents or all the household members will be beneficiary. So as I said earlier, it has been 10 years since we have started implementing CBHI, but the SHI hasn't yet been on ground, or it hasn't been launched. Design-wise, the social health insurance is supposed to be one national pool, and there will be one account to which all the collected money will go. But in the CBHI, it is very fragmented, and I will explain that in a few moments. Both are solidarity-based, unlike some other countries where the insurances are based on risk of individuals who are getting to be members. So this one is solidarity-based, so people will contribute to their capacity, but they will utilize services as per their illness. So that is the major motto behind the design. And that way, we think that we'll achieve equity. So to show you the design, at a district level, because our system started at a district level. So there are villages, and in the villages, there will be village leaders who will mobilize the community to get enrolled in the CBHI scheme after doing some mobilization and training for those village leaders. And those those individuals who want to get enrolled and who are interested, as per the previous, because now it has been just very few months since we have launched this mandatory scheme. So what I'm trying to explain majorly is based on the previous implementation. So those who are volunteered to get enrolled, they'll pay membership contribution and they'll get enrolled in the scheme. That CBHI scheme, which in most of the areas is district-based, will have at least 3 full-time staffs. This will be one coordinator who is usually health professional, one data-related professional, and the other one going to be finance-related professional. So usually they are accountants. So these CBHI schemes, once they collect the money and once they reach to a level where they can start the scheme, they will sign contract with facilities, health centers and hospitals in their catchment. And then because they issue an ID when they collect money, the people will go to the facilities, to contracted facilities. And once the facilities give the service, they will send claim requests to the schemes and the schemes will reimburse that one. These CBHI schemes are run by CBHI board, which are available at district level. And they are composed of mainly selected district leadership officers like the district health office, district finance office, the district administrator, or you can say chair, and communication officer, and like those who have something related with the scheme. And also there will be 3 representatives from members who will be in the board. So three representatives from the people who reside in that scheme, in that district. But the last governing board will be the last governing platform will be this General Assembly, which is composed of the village representatives and as well the district office leads, which will happen once a year. And then many of the things used to happen here, like for example, the premium amount will be decided at this level. This General Assembly will hear the financial status of the scheme, like how much money collected, how much was spent, and the like. Okay, so this is a final decision making body. The scheme's revenue comes from 3 sources. The first one is paying members. So members payment is like those who can afford to pay for themselves, they will pay the decided premium amount to get enrolled. The other is targeted subsidy. For those who cannot afford to pay for themselves, the local governments will pay on their behalf, and that is called targeted subsidy. And then the federal government will send 25% of the sum of those collected money. I mean, like from the premium, the members payment, and the targeted subsidy. So this will be the total scheme's revenue, which can be utilized by the scheme. There are 2 critical points here. The first one is the collected revenue will be used primarily for health service procurement, and it can be used in very small amount to ID preparation or to pay those who collect money from the householders during the membership collection or the membership enrollment process. So primarily it is used for health service procurement. Administrative costs for the 3 individuals who are employed at a scheme level, and as well other running costs of the system, the whole CBHI system will be covered by the government. So we can say that 98% of the money that's collected from the members or from CBHI revenue sources will be used only for healthcare related payment. When we see the benefit package, the CBHI covers all the outpatient care, inpatient care, delivery services, surgical services, diagnostic tests, and generic drugs. But it excludes, so as you see, it is implicit kind of benefit package, but it excludes these listed services. So treatment outside Ethiopia, injuries like that come from natural disasters, social unrest, epidemics, drug abuse treatment, periodic medical checkup, occupational injuries, cosmetic surgeries, organ transplantation, dialysis for for those which are not for acute renal failures, provision of eyeglass and contact lenses, in vitro fertilization, hip replacement, dental cares which are not due to infection, previous provision of hearing aid and health service provided to any beneficiary free of charge are those which are not covered, okay? So though we say this is a benefit package, lack of availability of supplies, shortage of human resources at some facilities, and shortage of some services makes this promised benefit package not to be uniform across schemes. So this is something that we are working on, and because of this, we can say that there is an inequity in somehow. To update you on the current implementation status, 89% of the districts in Ethiopia have started implementing community-based health insurance. Now it has been 10 years since we started CBHI. We celebrated the 10th anniversary a couple of months ago. So it started as a pilot 10 years ago, like in 2011-12. I mean, the reason why I am putting 11-12, 12-13 here is if there are some participants who are not Ethiopian, Ethiopia has its own calendar, so that runs somehow in two Gregorian calendars. Okay, so that's why I'm putting these 2 years, because we are implementing in our Ethiopian calendar. So it started by 13 districts, but now it has reached to 980 districts. So this is around 89% of the total districts. So we can say that pretty much we have covered almost every district in Ethiopia, but majorly there are regions. So there are regions who have blanket coverage, but in Ethiopia we have these few regions which we call emerging regions or developing regions, where the implementation of CBHI is a bit sluggish. When we see the membership, so the blue line shows the paying members and the red one shows the indigents. So if you remember earlier, as I said, the source of revenue is, as you see from the paying members, and as well the targeted subsidy is something that will be paid for the one that you see on the red line. Okay, so recently we just finished our enrollment period, and around 10 million paying members have enrolled, and as well more than 2 million households or indigents have been paid for to be enrolled in this system. So that means we have totally now more than 12.2 million households enrolled. And when we multiply by the average family size of Ethiopia, we can say that more than 55 million people are now enrolled in this system. So this means this is 82% of the eligible households in the districts where this has been implemented. So the membership coverage is 82%. And when we check how many of the individuals who were enrolled previously or last year have kind of renewed, we saw that 93% had renewed. So and 7% have dropped. This could be by multiple factors. And these 2 million households that you see on the red line, this is the indigents, and this is 76% of those indigents, those who cannot pay for themselves. So still, we do have some portion of the individuals who cannot cover for themselves, for whom we need to pay, and there needs to be a lot of work to be done there. To update you on the healthcare providers, these schemes, which I presented earlier, the 980 schemes, they have signed contract with public health facilities. So the community-based health insurance so far is signing contract or is engaging or buying services majorly from public health providers. And now we have contracted 3,459 schemes. Majorly they are health centers. In Ethiopia, the health care delivery, the healthcare tier is like the one you see here. It starts at the primary healthcare level, and there is a secondary healthcare level and tertiary healthcare level. So from what you see here, what we haven't contracted here, or what I haven't put here, is a health post, which we don't contract because we don't expect a curative care to be given there. So we just start by the health centers. And more than 3,000 health centers have been contracted, around 190 primary hospitals, 85 general hospitals, and 21 tertiary hospitals have been contracted. We haven't contracted non-public providers for the whole care but we contracted, or the schemes contracted, these non-public providers to fill the gap in the public facility. For example, when there is a stock out at the pharmacy level, so that the people or the members do not buy medications from out of pocket or by out of pocket, the schemes will contract community pharmacies or Red Cross pharmacies, or at times by some competitive bid or something, they will just sign with a contract with a privately owned pharmacies. Unless for those services where there is a gap in public facilities, we haven't yet contracted a private facility, and that's why we are doing a private engagement strategy now. The provider payment modality the schemes are using right now is majorly fee for service, but recently we have piloted capitation. So for the last starting from 2020, we have been piloting capitation as a payment modality for health center levels, and we have learned a lot of things from it. And now, because of the good things we have observed, we are expanding it to additional 40 districts throughout the country. But one thing which I want to mention here at the provider payment modality area is health facilities do have other financing sources. Okay, they will get money from those members who are not enrolled, those healthcare utilizers who are not members. They will get also a budget by line item budgeting from local districts, and they will use that as a running cost and as also to pay the professionals that they hire. So the money that they get by the fee for service payment and by capitation is just only for the drugs and supplies and just for the medical care. To say a few things about lessons learned, the CBHI implementation has increased service utilization because we have seen that by the recent impact study, which showed that householders in CBHI implemented districts utilize or who are enrolled in CBHI utilize more health service compared to non-member households, and as well households which are in non-CBHI implementing districts. CBHI has also reduced out-of-pocket expenditure. It hasn't brought it to zero because, as I told you, because of the challenge in the drug and supply and other factors, we haven't completely made the out-of-pocket expenditure to zero, but it has reduced compared to those householders who are not enrolled in this program. It has also increased the health facilities revenue, but this one hasn't completely supported in improving quality because, again, on the drug and supply chain, there are some gaps that should be addressed, and the inflation has also has some contribution on that one. But if we maintain this thing, I think that will have an impact sooner. One thing which we have learned also, the CBHI implementation needs political commitment, because those regions where the implementation is very good and where the coverage, the membership coverage is very high, are those regions and districts where the political commitment of local leaders is very high. Okay, so in areas where we lack political commitment, we do have a challenge to its implementation. One of the very big challenge that we need to work on, and which we have started working on, is a fragmentation. So because it was started during the pilot phase as a district-based scheme, it expanded keeping that structure. So now we have very fragmented schemes which do have very small number of members. And this should be, this should be addressed, because the cross-subsidization will be very small and the risk sharing will be very small when it is at a small level. As you remember, as I have told you, that it was voluntary based. It was voluntary based, it was a district based. So these two will create a very huge challenge for some districts, okay? Because it's voluntary in nature, there is adverse selection, and many of the individuals who would get enrolled very fast will be those who are in chronic care and the like. So that adverse selection has been addressed because now we have made it mandatory. So the mobilizers, the local leaders will have something to kind of base their mobilization and communication so that they will enforce many to get enrolled, okay? But the fragmentation hasn't yet been addressed, and there are some regions which have started to pool the district-based pools to a provincial level or zonal level pools, and we need to build on that one. We need to push that one, and then we need to bring a bigger pool. So that's all which I have as a presentation, but if you have questions, then I will come back. Okay. Thank you so much for your attention.
Yeah, thanks, Dr. Muluk. And I think this has been quite a fantastic presentation, and also just running through to our listeners in terms of where the story, especially the first graph you demonstrated around house, you can see progressively the role of EHIS and more so CBHI contributing to the as a contribution to the healthcare expenditure in Ethiopia, but at the same time trying to demonstrate how that has influenced utilization of care and how that has continued to shape the quality of care as well. And also and its role in reducing out-of-pocket expenditure. As you know, that's one of the aspirations in UHC, that how can we reduce out-of-pocket expenditure as one way of providing financial risk protection. And also, even at a facility level, trying to see how can we improve revenue, because revenue then is used for to cater for some of the operations within the facilities. And so I can see there's quite a lot of enthusiasm from the questions. And the other confusion I got was there are people who are posting the questions on the chat side and not the Q&A. Please do post questions on the Q&A side and less on the chat side, so that it becomes easier to fish out. But we'll be happy to look at through those who had posted on the chat side to look at the questions, but on the Q&A questions. And also feel free to put up your hand. So I'll be looking out for those with the hands up, just in case you want to speak out. But I'll probably kick off by maybe some of the questions that have come through on the chat. I know there's quite a number, so we'll try and see how much we can answer them. And if your question is answered, probably that can help also answer other questions. I think the first question picks a very important aspect, Dr. Muluken, and it looks at the table that you shared earlier that showed the, slowly how out-of-pocket spending has been reducing over the years, but also just in terms of how the increase in CBHI in terms of its contribution to the health sector. So the first question is, how has Ethiopia been able to decrease the out-of-pocket spending from 52.7% to about 30.5% in 25 years? Are there any sort of ideas that you have, especially from the health sector in Ethiopia, that you could share with us? Over to you, Dr. Muluken.
Thank you for the nice question. And for noting that one. So the out-of-pocket expenditure reduced not primarily because of OOP only, but is because of the essential health service package and due to the exempted services. Okay, in Ethiopian health system, there are services for which householders will not pay. For example, the maternal and child health care, mainly malaria, TB, and HIV, all these things, people will not pay for getting services on these cares. Okay? So this has helped a lot. And also, the services that are provided at the health facility level are majorly subsidized by the government. Okay, so people will pay, even though it is even though as out of pocket, they will pay for drug and medication and the like, because the running cost of the facility and as well the human resources who work in the health facility are paid by the government as a line.
Hi, Dr. Muluken, are you still there? Okay, I think you had gone off. Okay, go ahead.
Can you hear me now?
Yeah, now we can hear you, yes.
Sorry for the interruption, and I don't know where I was lost. Anyhow, there are two major reasons. One is because the government is subsidizing the healthcare a lot. The running cost of facilities, the human resource cost of those professionals who are working in the facility is being covered by the government. So the people are paying only for the medicine and supply. Okay, so one critical reason is that one. The second one is exempted services. Okay, maternal and child health care is provided exempted or free of care, okay? And as well, TB, malaria, and HIV-related care are being given for free. So because of this, and there are other things that are being done, because of these things, the OOP has reduced. So the two critical factors that comes to my mind very fast are these two. But also we are also observing CBHI is contributing somehow to this one, but not to that much big significant level. So I am not saying that the CBHI is a major contributor for the reduction of the OOP, but it has helped, okay, when we compare households who are enrolled and who are not enrolled, it has helped, and it has its own contribution.
Good. Thanks. And so something else that has come up quite strongly, and I wish to combine a couple of questions, especially around enrollment. I know, it's probably something that you mentioned, but happy to hear, maybe clarification from your end. Is the CBHI at household level, or if the CBHI, if in the CBHI the household head is the main member, does it mean that the premiums must be paid for each of the beneficiaries? So I think the answer that the question that they're trying to ask is really at what in the contribution, is it at a member level or a household level? I think that would be an interesting one to get from you. And then something else that has come in quite strongly is around, still on the same, how do you address equity? And especially at the enrollment stage, how are you taking care of the people that are not able to afford in that? And also someone, especially around the same train of thought, is asking, is there a plan to integrate more of the 750 CBHI schemes to increase efficiency? I know you mentioned around fragmentation as one of the weaknesses, so it would be interesting to see maybe from your end whether there are plans to integrate that. Maybe you could pick that from your end. Over.
Yeah, thank you so much for those questions. The contribution is household based. To answer it very shortly, it is household based, so it's not beneficiary based. But in some of the regions, just to address some community rumors and community questions and the like, they try to design the payment based on the number of individuals in the household. Okay, so this is just in some areas. Okay, this is not the national design. The national design is the households will pay. Can you hear me?
Yeah, we can hear you quite clearly. Yeah. Yeah, Dr. Moluken, we can hear you quite clearly. If you can proceed.
Can you hear me now?
Yeah, we can hear you. Proceed.
Sorry for the interruption. I would like to apologize for everyone because this is because of the connection. So the households, the enrollment is by household level, but in some parts of the regions, in some parts of the country, they change or they design it in a way the contribution will go higher when the number of individuals who are in the household increases. Okay, this is in a very few areas of the country. In most of the areas, the payment is just by household level. And it's not based on like exactly related with the beneficiary. So the payment is per household, but when there are individuals, I mean, like, for example, if in Amhara region, in one of the regions, they made it in a way when it's less than 5, they pay something. When it is between 6 and 8, they pay something. When it's above 8, they pay something and the like. So they try to stratify it by that. But in many of the areas, it is household-based payment.
Okay. Good. Thanks, Dr. Moluken. And I wish to maybe, I know we have people online that have their hands up. So I'll wish to maybe look at maybe pick 2 questions from, I know someone, I can see someone who has had the hand up probably the longest. So Ebuka Nwafia, please go ahead and ask a question, and then I'll give a chance to Yameogo to ask the question. Over to you, Ebuka.
Okay, thank you very much for the wonderful presentation. I just wanted to ask the level of the political will, and also to know the specific sustainability plans in place to sustain the community-based health insurance scheme. Thank you.
Good, thanks. So I'll hand over the next question to Yamiogo Bonaventure. Yamiogo? Maybe you can unmute because I can see you on mute.
I'm really sorry, this is very terrible. Can you hear me now?
Yeah, we can hear you. I don't know whether you got the question from Ebuka Nwafia, Dr. Mulligan.
What was the question? Sorry, I haven't heard that one.
Ebuka, do you want to give it a go again?
Okay, can you hear me?
Yeah, we can hear you. We can
Yes,
hear
yes, we can hear you.
Okay, I just wanted to know the level of the political will from the government, the support the government is giving to this scheme, and also to understand the sustainability plan in place to sustain this fantastic initiative. Because I know for Nigeria here, community-based insurance scheme is not something that is quite that is quite robust. What we have here is mainly focused on the formal sector. So I just wanted to know how Ethiopia has been able to navigate the community health insurance scheme successfully to this point. Thank you.
Okay.
Can I go through it?
Yeah, maybe one more question. One more question for you, Dr. Muluken.
Okay.
From Yamiogo. Yamiogo, you're on mute. Okay, it seems like there's a challenge from Yamiogo. So can we move to Nahum Tamrat? Nahum Tamrat, could you please unmute and ask a question? Or seems like there's a challenge around unmuting. But anyway, Dr. Mulken, you can go ahead and answer the question as we sort the audio from the other end. Over to you.
Good. Thank you so much. So just to show the political commitment from the government side, recently we just launched a national level proclamation. That's one sign that the government is committed because it was enacted at the House of People's Representatives. Before this, the inaction or the endorsement of this proclamation, the general subsidy from the federal government was only 10%. Now it has increased to 25% of the collected money at the district level. So this shows government commitment. There is a national council which is established where the deputy prime minister will be the chair, and presidents of each regions or the states in Ethiopia will be members. This shows again another
Dr. Mulken, we've lost you. I don't know whether you can hear us.
Can you hear me?
Yeah, now you're back. Go ahead. Yeah, Dr. Mulken, we can hear you now. Please go ahead.
Yeah, so the increment of general subsidy from 10% to 25%, the establishment of national council where the deputy prime minister will be the chair and the presidents of each state will be members. And also the fact that it will be the district who will pay the insolvency. Like if a district fails to cover the expenditure, it will be the district government who will pay that gap. Okay, so for example, if a district collects 1 million, and when the district pays, it becomes to 2 million, and there will be a deficit of 1 million, that will be paid by the district government. So this has been enacted on the proclamation. So all this shows that the government is committed and it's on the ground. It's being seen in the ground. So this shows the commitment. Sustainability-wise, and as well to address the issue of how we are planning to pool the fragmented districts. Yes, we are working on that one. As I was mentioning during the presentation, there are some schemes who are pulling together and are creating the scheme at a provincial level rather than at a district level. So the number of households will be bigger, and the risk that will be shared will be bigger. And the plan, on the strategic plan of our Ethiopian Health Insurance Service, is to create one national pool at the end. So it will grow from the district to zonal level. We have one region who have established the scheme at a regional level rather than at a district level. They have established it at a regional level. So we want to pool all the districts to provincial level and to regional level, so that we will have again a national pool where all the regions will come together. But this is very early to say, I mean, like this will happen very soon, because the plan is also to have a kind of paper-based design by the end of the 10-year strategic plan.
Okay, fantastic. So before we go to those who have raised their hands, there's something that keeps on coming up from the questions around enrollment.
Mm-hmm.
So one is, you seem to have a success rate of renewal at about 93%, which is quite fantastic. So the team would like to know, how did you get there? And the other bit is, especially around the pastoral communities, how you're ensuring, enrollment at that stage. Are you experiencing challenges, and how are you going about it? Over to you.
Good. So the 93% achievement is majorly because of the political commitment. Okay, the awareness creation, the mobilization, and all the activities that happens during enrollment period is being led through the follow-up and the monitoring and evaluation of the political leaders. So this has helped in the increment in the enrollment. And also, I mean, when we start, it is just us who are communicating, but during the implementation, those who have utilized the service, those who have utilized the service and have not paid anything, will help us in communicating more. Okay, this has helped a lot, and as well the inflation in the medical sector or in the country as a whole, compared to the amount of premium that the households are expected to pay, is very different, very much hugely different. So there are many factors that will help in renewing. But still, I'm not saying there is no gap in the health service quality, and that is something which we need to work on. And the dropout shows that one. Regarding to the implementation in pastoral areas, so those are the areas where we are lacking to implement. Okay, so the reason, so when I was presenting, I said that the coverage is 89%, and in many of the regions we have blanket coverage, but there are regions where we are lacking. So these are the regions where we are lacking, okay, the pastoral region, because they are moving. We do have difficulty. So we are recently also starting to implement it there, and also we have done some. I mean, like some design analysis as to how to implement CBHI there, because the people are moving, how we can enroll this population and how they can be communicated through the facilities where they are moving and the like. So there is a new pastoral design that we are working on, but yet that hasn't been ground. But yeah, that is the area where we are having the challenges. So the question is right. It is challenging to implement it in pastoral areas.
Good, thanks. So back to the, I think certain people that I had already pointed out. So Yamiogo, I don't know whether you can hear me, and maybe unmute. Okay, maybe Nahum Tamrat, are you able to unmute and maybe ask your question? Okay, I'm not so sure what's happening. So Fanis Ajore, are you able to ask a question? I don't know whether the IT team can facilitate the unmuting so that we're able to get a few questions from the teams, but maybe as that is working out. So the other bit is that maybe I can proceed with some of the questions on the chat. So there's the conversation that we had around contracting of providers. and modalities of payment. I think there are a couple of questions that are coming up, quite a number, but one of them that I'm happy to choose is, what about the private clinics? I know you mentioned around mostly the public sector, and you mentioned some of the exceptions, especially what you're terming as a non-public sector, looking at, I think, the Red Cross pharmacies and a couple of others that you mentioned. But what about the private clinic? How has that been? And the second bit that is attached to that is, especially around the mode of payment, which we can link to the choices around who you're contracting, is what is the major reason for making capitation payment for PHC? So maybe just a rationale around choosing capitation. I think that's something that a number of people will be interested in hearing about. Over to you, Dr. Muluken.
Thank you, Dr. Matiko. So with regard to engaging the privates, we are working on a private engagement strategy. So far we have been engaging them only on the areas where there is gap in the public facilities. The reason why we are having difficulty is the collected money. The public facilities, they request us to pay only the drug and supply part because they get a line item budget from the government. So if we have to contract the private facilities, we have to cover the running costs, we have to cover the human resource costs and some other indirect costs too. So doing that will make it very inequitable to assign some individuals to the private and some individuals to the public. If we have to do that, we have to collect some additional money, which considers these additional costs. And doing that will be, again, needs some work. And as well, when we pay, as you know, the public facilities, because we are a public institution, the schemes are public, the fraud will not be that much big, even though there is still a fraud from the public side also, okay? When you do it for the private facilities, unless you control it by some forms of payment.
Hi, Dr. Muluken, you've gone off.
Yeah, can you hear me?
Okay, you're back. Go ahead.
Yeah, so the resource mobilization part didn't can you hear me?
Yeah, I can hear you. We can hear you.
So the resource mobilization part they haven't considered the covering the human resource cost, the line item budgeting and the like. So that is one reason, as I say. And also when it is with the private providers, definitely we know that in insurance, healthcare providers want to get more money, so there will be moral hazard from the provider side, and that should be well addressed also on the payment modality. So far, we are paying only fee for service. If we continue like that for privates, it will be very much consuming, and there should be some design to which will help us address that part. So these are some of the reasons why we are not directly engaging the privates, but we know that there should be an engagement plan, engagement design, and yeah, that is what we are working on. So the reason why we haven't engaged them so far is because of the design feature we have is a bit difficult to engage them right now. Can you hear me?
Yeah, we can hear you quite clearly.
Yeah, so that is one of the question. Can you remind me of the other?
The other question was around the capitation for PHC.
Yeah.
Like, what's the rationale of choosing capitation for PHC?
Good. So capitation is like already a well-studied and well-documented payment modality, or a well-recommended modality for primary health care. But the point is like how you calculate the per cap amount, how you assign households to facilities, how you monitor facilities so that those gaps of capitation would not be observed, and the like is something that we need to work on. Okay, so what we did in Ethiopia is to help us understand how we need to calculate the per cap amount, or the rate with which we pay the facilities, and as well how we can assign households to facilities. And also we wanted to check also when we started capitation if facilities will start referring out, will start reducing, doing investigation, will start giving service only for those healthier patients and the like. So as per our study, we haven't noted these negative impacts, but computing the rate was very difficult, and the recommend that to be the payment modality for. Can you hear me?
We can hear you. Can hear you. Yeah, go ahead.
Hello?
Go ahead. You can. Yeah, we can hear you. Go ahead. Hi, Dr. Mulukan, please go ahead. We can hear you.
Yeah. Okay. I recommend capitation to be the payment because that helps the facilities to be cost conscious, and also it helps the schemes to control their cost, and also administrative wise, rather than doing fee for service payment, which needs us to go through all the claims to check if there is no fraud and the like, and if all the claims are correct and the like. It would be better administratively, or it will be less demanding when you do it capitation wise. Okay, so I recommend also capitation to be the main payment modality for primary healthcare facilities, but I mean specifically the health centers. But the biggest challenge is computing the per cap amount. Okay, we have done it two different ways. The first one is based on the health service expenditure of the facility, and based on the health service utilization in that specific area. In the other round, or in the other year, we calculated it from the amount of collected money and the amount that could be shared for primary healthcare facilities and the like. So both ways, we have faced some good things and we have faced also some challenge. So calculating the per capita amount is a difficult part, but paying it ahead is helpful for the facilities to have a predicted amount of money to procure medications prior to the request of service, so that they can avail more quality service and the like. So there are very many positive sides of it, but yeah, computation is very challenging.
Thanks, Dr. Mulukan. So I note that we only have about 2 minutes to the end. And I don't know whether we can have maybe Nahum, I don't know whether you're able to ask the question. I know I have two people that have their hands up, Nahum and Tadele. Nahum, are you able to ask the question? Please go ahead and unmute. Nahum, are you there? Okay, Tadele, are you there? Tadele Dolio, please go ahead and ask the question.
Hello, is that audible? Hello, doctor.
Yeah, I can hear you.
Yeah, go ahead.
Okay. Community-based health insurance is the most important thing, while what I have seen while during my clinical practice. So it helps us to evaluate in investigation, to provide treatment, also to refer our patient to better setup without hesitation of the cost, because it is covered by the insurance the patient already contributed. But still the amount of money that contribute for this insurance is low. So if the government has a plan to increase the amount of household payment every year? Thank you.
Shall I respond, Dr. Matiko?
Yeah, please go ahead, Dr. Mulukan.
Yeah, that's a very good question. Yeah, we are revising the premium amount, and after the new proclamation, it should be endorsed at the national level. Yes, we will increase the premium amount, but that will be up to the level of the ability to pay of the community. So we have a study which was conducted recently, which goes which looked into the willingness of the community to pay and the ability to pay of the community. So we are revising the premium, and we will set it to the level where the people will be able. And as well, as I said, so far, majorly it is a flat rate contribution, but now we are planning to stratify it based on income level. So those who have higher income will be expected to pay very high, and those who have lower income will be expected to pay as per their level of income. So there will be stratifications that will come soon.
Fantastic. So I'd like to push the last question, because I also know we are past time. It's also a question that always comes in insurance. It's always a question that comes up in health financing around what is the role of CBHI or any form, our, SHI in the contribution they make to prevention and control of diseases. I know you highlighted around what services are covered, but I think quite a number of people asking around what about prevention? Any thoughts on that, especially around the bits that CBHI is doing, Dr. Muluken? Dr. Muluken, you're on mute. Maybe you can unmute yourself.
Sorry, I forgot to unmute myself. So directly, we are not paying for preventive care. What we are covering, or what the schemes are covering, is only curative parts of the care. While we are implementing capitation, what we noticed was indirectly the facilities were working on the preventive care to avoid or to reduce their expenditure. So. And also the design we have is somehow fragmented at a bigger level, even at a country level, because the exempted services, which cover most of the preventive cares, are covered by the donors or the federal government, or by some other forms of financing. So they are not covered in our system. So I can say pretty much many of the costs that we cover are on curative cares. But this is bearing in mind that some of the curative services are also preventive cares for some more complicated cases, So because people can come to facilities without worry, they may get diagnosed early for be it for cancer, be it for cardiovascular diseases, and the like. That will somehow help in preventing more sophisticated things. So I cannot say that CBHI is directly investing or directly working on preventive cares for the time being. I'm not saying that it will continue this way in the future, but for the time being, we are just covering only the curative part. But because of 2-3 things, it's indirectly working on the preventive. One thing, it helps people come to facility, which means early detection is one prevention. Sorry. The second thing, where we are working on capitation, we have seen that facilities are working on preventive activities more to reduce their own cost, because we are paying them ahead of time. So the design is that way. But I'm not quite sure, but in Rwandan system, I think they have included this, what we call exempted service, the maternal and child health services, or those services for which donors are funding, will fall into the scheme's benefit package. So ours is not like that. So I think that could be something which we will work on, because the Ministry of Health is working on how to finance exempted services right now. And I don't know, somehow in near future, the exempted services could come to us, and the finance might run through our organization. Thank you.
Good. Thanks, Dr. Muluken. I know we've overshot by about 5 minutes beyond the time that we had allocated. So, and I know there's quite a number of questions that have come through, about 60 questions, some even more on the chat section before we give clarification around where to put the questions. And so I'll wish maybe for us to end there, but also with a promise that we'll have all the questions addressed and maybe then shared later to, I think they're very interesting questions that the audience would like to get some of the answers. So it's something that we will get them maybe a quick summary and have them answered and probably shared in a platform. So I'll wish to maybe hand back to, Dr. Antene, especially around the next steps, what the next conversations will be, especially around, one potentially will have a similar presentation by the Rwanda team to hear more about Rwanda. The most interesting thing, especially about Rwanda and Ethiopia, is as you'll note, and probably what we'll have wished to learn today, is just seeing how two countries across the continents are traveling the same journey in terms of building a robust community, through, going to a path of integrating a broad community-based health insurance and making quite a success. So that's something that I'm happy to hear from Dr. Ntene and team, and then we can plan and have the next session with you. So over to you, Ntene. I don't know that he's still there.
Well, he's not there, Dr. Machiko, so you can summarize. Thank you.
Okay, good. So thanks again, and we'll keep you in. We'll keep communicating around the next steps and the upcoming conversations. This is a start of many other conversations we are going to have to share. Across the continent, what's happening, especially in the space, to improve access to care, and as we drive towards universal health coverage across the countries, across the continent. So thanks again, and really looking forward. Again, even before we wrap up, a number of you might be aware there's an upcoming conference on PHC, which will be held in Ethiopia around September, mid-September, so that the dates will be communicated to you. So please feel free again to keep an eye on that. So more of this conversation will be coming up during that time, but in a lead up to the conference, we'll have a lot of other webinars coming up to try and share lessons from across the continent. So thanks, and have a wonderful evening for those who are in the on this side of the planet, and maybe those that are starting the day also have a good morning. Thank you.